In the aim of fair and open science, after the completion of this presentation, all these slides are going to be available at the digital object identifier location shown on the screen here. So I'm going to speak today a little bit from a perspective of a clinical trialist and imaging scientist, and then talk about how integrating open and fair scientific practice into that construct can be potentially synergistic or transformative. These are my funding disclosures, which I will flash by too quickly for you to read. Fundamentally, as a radiation oncologist, our field utilizes imaging in a way that is unique. As oncologists, we are unique because spatial dose response is the core of what separates us from other cancer paradigms, like medical oncologists who give systemic chemotherapy. Historically, radiation therapy, for those who are not familiar, involved us using a limited number of radiation treatment apertures or beams, and then firing radiation from multiple sides to encompass a tumor volume, here displayed in red. And if you could give enough radiation dose, you could kill the tumor, and ideally give it at a dose that did not destroy or kill the normal tissue around it. This is problematic, however, because you can kill any tumor with enough dose, but what about the human being that sits around the tumor? The tumor is here, but there's all of this anatomy that is surrounding it, and patients have organs at risk which have very different side effects at different radiation doses. And historically, in head and neck cancer, we worried a lot about the parotid glands, these spit glands on either side that are important for salivation and speech and swallowing, which happen to be exquisitely radiation sensitive. So in the old days, when we treated with this technique, the same dose that was received by the tumor was received by the parotid glands, and the vast majority of patients had terrible dry mouth, so bad that they couldn't swallow or speak for the rest of their lives. In the late 1990s, a technique was developed where we could modulate the radiation dose. And so instead of everything in the radiation field getting the same dose, we could kind of spread that dose around. And by doing so, we could spare these very sensitive parotid glands and move the dose to other structures. But the problem is, when we did that, we just moved the dose and traded dose to parotid glands to dose to other structures. And there are a whole host of radiation effects which can be observed in any tissue of the body, because the head and neck is a very important area in terms of real estate. So initially, this results in things like radiation changes. There's these intermediate effects like changes in the airway that are involved in swallowing. And then in years after treatment, patients can have damage to their bone or necrosis and death of existing tissues. And this is really highly tied to where the radiation dose is. So for example, this is a radiation plan. Here is the tumor. These outlines represent various radiation doses that are delivered. And you can see in this patient, the front of the mouth receives very little dose. The back of the mouth where the tumor is receives high dose. And during treatment, you can see that this patient develops a kind of sunburn or desquamating effect in the posterior aspect where the radiation dose is. And you can see these skin changes as a function of the radiation dose to the surface tissue, all the while trying to eliminate these tumors that you see. And you can see how the relationship of where the dose is related to the tumors. A couple of things that changed in the course of this, in the course of these years, is our radiation treatments improved, but in head and neck cancer, we also had a really important paradigm shift. We realized that there were certain head and neck cancers that were associated with human papillomavirus exposure, which about 50% of us in the Western world are exposed to through sexual contact. And if we weren't vaccinated as children, this can lead to cervical cancer, head and neck cancer, or anorectal cancers in patients who are exposed. We found that those patients who had human papillomavirus positive cancers had exceptionally good survival, whereas those patients with HPV negative cancers had very poor survival. So suddenly we had a group of patients who were much more likely to live years and years and years and years and years. And so our ability to reduce or modify the radiation dose became very, very, very important. Historically, when we treated with a radiation field like the one that you see right here, the same radiation dose was given for a 6-week period, Monday through Friday, 5 days a week, over a 6-week interval. And this was because at the time we would take the initial imaging of where the tumor was. So going back to this patient, here's where the tumors were at the beginning of therapy. We would design a radiation plan and we would continue that plan all the way through treatment because we really couldn't see many differences in the tissue. One of the things that occurred also in 2011 is that the University Medical Center Utrecht began to implement a combination radiation delivery device and MRI. And this was pretty exciting for us because we realized that there was a real opportunity space. Previous to that, our daily capacity to image the patient was CT based. And as many of you know, CT is not as good as MRI for seeing soft tissue anatomy of the head and neck. So when we saw changes in the patient during treatment and we had to make modifications, because we couldn't see where this tumor volume was, we couldn't adapt any more than if, let's say, here's the patient losing weight. We could adapt the radiation plan to the patient's contour or outline, but we couldn't adapt the field to the area where the tumor was. Even so, some early data suggested that we could potentially reduce patient side effects just by adjusting these changes on the CT scan. So some early work done at our facility used a CT acquired every day. When the patient lost a lot of weight, we adjusted the plan to spare these parotid glands, which were overdosed. But we see that there's limits in that because the limitations of the treatment paradigm, when you can't really see the thing you're trying to target, the tumor, and you can't see the normal anatomy very well. And recent attempts at adaptive radiotherapy using CT-based replanning have been unsuccessful. So a recent study designed to compare in about 88 participants with adaptive radiotherapy or standard radiotherapy using CT-based weekly adaptation did not show any significant difference. We believe that for some degree, that's because, as you can imagine, we can't see the tumor on the image and the normal tissue is often difficult to see. Whereas on the MR, it's quite readily apparent where anatomically, the tumor location and the normal anatomy, the muscle and the bone and the soft tissue of the parotid and glands are. But where we want to move is from this present activity where we're looking at anatomy to a future where we're incorporating functional imaging. And this is a possibility with MRI-guided adaptive therapy. When we started imaging patients with MRI at fixed interval during radiation therapy, we were stunned to see that approximately half of our patients who had viral cancers had such a rapid response to therapy that there was no visible tumor by the middle of radiation treatment. So halfway through treatment, we were using a plan designed to treat a tumor that might be 3 or 4 centimeters across at the beginning of treatment that had entirely become microscopic or subclinically evident by the middle of radiation, which suggested that if we could just adapt to where the tumor was in closer to real time, we could significantly reduce the radiation dose. As you can imagine, if you start treatment and you're treating a tumor that's this size, that looks very different if you continue this through all 6 weeks of radiation when the tumor is only this big in the middle of treatment. So this idea of anatomic adaptation was one that we felt like was a very low-hanging fruit with the capacity for daily imaging. So with my colleague Abdullah Muhammad, we began some early studies where we attempted to map out the kinetics of MRI-guided anatomic changes. And what we saw was the first week of radiation, there was rarely much change in the volume of the disease, but over the intervening weeks, there was a rapid reduction in the size which could result in radiation dose reduction to all those normal tissues we're worried about. The thing that was interesting when we did this pilot study was that not all patients benefited the same. So that is to say that while we could look at population averages, some patients had exceptional changes and therefore dose reductions available, whereas some patients had more modest ones. This has resulted in a clinical trial where we are doing just that. As the tumor shrinks, we shrink the radiation field on a daily basis. When the tumor is gone, we reduce the high dose region. And we've enrolled 62 patients on the randomized component out of a planned 65, which was really attractive. The idea of doing this on a daily basis with an integrated machine, however, came with some challenges. While we all kind of accept that MRI is better at soft tissue visualization than CT, when we initially got the MRI linear accelerator device and we began to look at the images on the device, one of the problems was the anatomic images came without fat suppression. And as radiation oncologists, it's incredibly important for us to be able to see contrast to noise between the tumor volumes and the normal tissue. So we had to optimize fat-suppressed T2-weighted MRI in such a way that we could see not only the anatomy, but also the tumor and lymph node volumes, which are seen here. This required us to take existing radiologic sequences, which might be great for diagnostic implementation, and repurpose them specifically for radiation therapy, while ensuring they had a level of spatial fidelity and lack of geometric distortion at levels that are typically not seen with standard diagnostic approaches. And again, these kinds of workflow issues had to be developed by our team. My colleague Bridget McDonald has presented our early work in a systematic paper detailing. But as we move from the idea of anatomic adaptation to functional imaging adaptation, the potentiation of having daily information, not just about the volume of the tumor, its location, but also physiologic parameters such as diffusometry became really exciting. And again, you can see here each day we could get the T2 weighted imaging and see where the tumor was, but then we could acquire apparent diffusion coefficient maps using DWI techniques to identify what was happening in terms of surrogates of cellular density. As many of y'all are aware, DWI is used in a very simplified way by many oncologists as a rough indicator of the relative cellular density of a substructure. And again, if we think about effective therapy as inducing cellular death or apoptosis and leading to an alteration in water restriction or restricted diffusion, the ADC in many cases has been associated with response to therapy as a biomarker indicator. And Simon Boke and Daniela Torworth were among the first in our consortium to demonstrate that we could accurately measure and track diffusometry on the MR-Linac device in a way comparable to that with diagnostic MRI. So this is work by Daniela and Simon, where they showed the ADC alteration over the course of a series of fractionated radiotherapy. So as we move to 33 treatments, these daily images could then be used for quantitative information. Now, this correlates with previous diagnostic imaging data that showed that early changes in ADC throughout radiation could potentially be predictive of outcome. In the pre-HPV era, there were several small but compelling studies that suggested that threshold changes in ADC would predict which patients would progress or have freedom from progression from their tumor or have remission or recurrence, depending on changes as early as the 2nd or 4th week out of 6 weeks of radiation therapy. One of the key features, though, that we run into in radiation therapy is that spatially accurate biomarkers are necessary if we're going to be changing our dose prescription based on that information. So while you can see, here's a reference anatomic image on the T1 TSE. This DWI using EPI techniques is so distorted that work by Tim Skakel and Mario Philippins has demonstrated that this might be usable for assessing ADC values, but it's functionally useless if our goal is to target these subvolumes. So with Marielle and her team, we have worked quite hard over the last few years to develop spatially accurate DWI techniques. So on the MR-Linac, Bridget McDonald has shown that while EPI techniques provide nice signal-to-noise ratio, their poor geometric accuracy limits their implementation. TSE approaches have better geometric accuracy, but at the cost of SNR. But we can use techniques such as modified parallel approaches for TSE and achieve excellent geometric accuracy and acceptable SNR in high contrast settings. But this requires an enormous amount of unsexy but scientifically important work doing serial permutations on human studies to achieve efficacy in terms of determination. Nonetheless, we feel like this work has paid off. Early work in looking at diffusometry metrics using intervoxel incoherent motion from Yao Ding and our group has shown that these early changes in the second week of therapy can be correlated with both lymph node and tumor recurrence. And our pilot data suggested that we could then use these as components in an adaptive workflow. By bringing in then a software architecture to bring functional biomarkers through inter-sequence registration, we could then read in the ADC maps and then track region of interest specific ROIs. This has then led to a series of efforts designed to both integrate and threshold the actionable values, but also to qualify these as biomarkers. So in the United States, FDA has a terminology called BEST, where there is a specific workflow for defining and qualifying a biomarker for clinical use. So one of our goals has been to do prospective clinical studies in head and neck cancer patients with diffusometry using standardized acquisition methods to determine and define this as an FDA-approved, or not FDA-approved, but FDA-defined biomarker. We started by looking at serial changes to detect biologic alterations during the course of therapy. So on a prospective observational trial, we were able to demonstrate that there were significant differences in pre-treatment measurements on the patients in terms of volume, and then we could relate those volumetric changes to changes in ADC values. And you can see that there was significant interpatient variability, but a highly conserved kinetics of these response patterns. What was also interesting is we saw, as you can see here, that there were differences in primary tumor and lymph node, which may have physiologic and therapeutic implications. We were then able to take, after week 2, a discrepancy in these trajectory tells us that the changes in the physiology of metastatic lymph nodes from cancer and the primary cancer are distinct, something that we did not know before. And therefore, we may need different approaches to nodal cancers as opposed to the primary tumors that spawn them. Moving that forward in a pre-qualification study, we performed a series of measurements in the tumor, and were able to find that the trajectory of patients who were responders who had full resolution of disease during therapy were distinct from those that did not, and correlate these weekly ADC changes with alteration over time. And then finally, in a second study, a large-scale serial prospective observational study, we were able to determine relevant thresholds which could differentiate, we believe, responders from non-responders at a level that could be implemented within clinical trials. So now, what does then the future hold? We aim towards biomarker image-guided adaptive therapy, where we could use that spatially accurate information and potentially move radiation dose to the areas where there is still active restricted diffusion, and reduce the dose dynamically on areas where there is a lack of that. The idea is that individual patients might have dose escalation or dose de-escalation, not at the level of the patient or the level of the tumor, but the level of tumor subvolumes based on the MRI. However, as we think of this, it's important to understand that we must contextualize all of the work that we're doing in the context of open science. Open science, as many of y'all are aware, has multiple benefits to multiple stakeholders. Everything from greater access to research, greater access to the general public, and faster transmission of knowledge. So one of the things that my lab group has been committed to is UNESCO's open science construct. So when we do a talk like this, this talk becomes a digital object in a open repository. When we use code for developing new sequences, that code, if not commercially constrained, goes on GitHub. Open access publication is undertaken, and again, trial data and data from these studies needs to be deposited. This open science motif is one where we move through open source, open access approaches to the next step is making all of our data and code co-published at the time of presentation as we move towards open science. One of the things that has facilitated that is that NIH has stipulated that all biomedical research should adhere to FAIR principles. And our NIH-funded publications now, as of 2024, must publish their data at the same time that they publish the results of the study. So moving forward, data publication will be an important part of every one of our efforts. I assume everyone here is familiar with FAIR. The Force 11 document is a great read for any scientist, but it stipulates that all science should be findable, accessible, interoperable, and reusable. And this is especially important for those of us in the MRI community. So if you think about FAIR data sets, what this means is that we need an individual identifier for content. It should be findable through known repositories. Accessibility should be stipulated in such a way to maximize access while respecting patient safety. The data should be interoperable using software formats which are easily both human and machine readable. And there should be capacity for reuse of data sets. And this becomes very critical. For those of us in the clinical trial community, this starts with the idea of pre-registering our clinical trials, but also one should pre-register things like observational studies or imaging studies. Pre-registration then allows that data to be linked and found at a later location. Registering this from using Open Science Foundation or other pre-registration sites is something I encourage for every imaging scientist, because by pre-registering these projects, you free yourself from the capacity to do things like accidentally p-hack or accidentally implement methods to find significance where there might not be prima facie evidence. The other thing that we've leveraged in the lab successfully is all of our papers are encouraged by NIH to be set forth as preprints. Preprints means that the second that these are submitted for peer review, they go on an open access preprint server. So people can access our science while it's being reviewed by radiology or imaging journals or radiation oncology journals. So the science is already in the public domain and can be assessed and can be accessed even before it's undergone complete peer review. We follow recommended guidelines and select preprint repositories that use FAIR principles. We typically use medRxiv, arXiv, or bioRxiv, but there are a host like Zenodo that are also very, very good. Preprints are a huge benefit because they allow our data to be accessed as well if it's made publicly available. It allows end users to access that with a speed which we think enhances the scientific enterprise generally. And fundamentally, this in no way takes away from the final peer-reviewed publication which is linked to the initial preprint, and then can be shared as needed. Our other, the other consideration that I think is incredibly important is bringing in the idea of fair reporting guidelines. So as you're undertaking these imaging studies, there are a series of equator network defined reporting guidelines for almost every kind of research. If you're using observational case control studies, there's a guideline called MOOSE. If you're doing a randomized trial, you have CONSORT. If you're looking at pooled results from prior data, INTRIGUE. So almost every kind of science can be made more fair and more reproducible by using a reporting guideline. The next frontier, we believe, is open code. And this is especially hard for those of us in the imaging community because oftentimes sequences are proprietary or vendor defined. A lot of the analytic code may be vendor specific, but whenever possible, we really want to move into open code so that people can reproduce our results. We've done some work in dynamic contrast enhanced MRI that has been incredibly difficult to scale because the code is not imminently available. Luckily, I think as a community, we're seeing the value of that, and the fact that imaging is one of the more highly awarded grants for open source software points to the unmet need, but also our need for a future commitment to open science as we move forward. Finally, at the end, I would highly recommend publication of data descriptors. So now when we publish data, if there is associated data publication, we can also publish that as a separate paper in journals like Nature Scientific Data or Medical Physics, where either the code or the data set can have its own reference, descriptor, and digital object identifier. This helps people find your data, use your data, and it very quickly is able to link so that people can find that. So we, for example, then have repositories like the Cancer Imaging Archive. You can find in the original paper a link to the data. You can find in the data descriptor a link to the data, and that points you to exactly where you can go download the data. For this example, one can go to our publication. You click on a link where the open data is. It takes you to a digital object identifier that takes you directly to TCIA, and you can download all of the images that we used for that project. So with that, I'll pause and take questions. I think as imaging scientists, our opportunities are unlimited if we share vision, and I hope that this information has been entertaining or useful.